Hi, I'm Madeline Joseph, the immediate past president of the Florida chapter of the American Academy of Pediatrics. I would like to acknowledge all our supporters, especially the Florida chapter of the AAP and the National AAP through the funding of Healthy People 2020. With their support, this training was made possible, and I hope you enjoy it.
Thank you for joining us for part 2 of this webinar, Treatment Approaches for Adolescent Depression. I'm your host, Elise Faluco. I'm a child and adolescent psychiatrist at the University of Florida College of Medicine in Jacksonville, where I serve as director of the Center for Collaborative Care. The learning objectives for today's presentation are to determine when and how to use SSRI medication to treat depression, how to monitor for side effects, and determine response to treatment. The mainstay of treatment for depression involves psychotherapy. Cognitive behavioral therapy is one therapy that has excellent evidence base for the treatment of adolescent depression. Now, when you're referring patients for CBT, what you want to remember is all PhD level providers are trained in CBT, so you'll know they'll be able to do that. However, if you're referring patients to other level providers, it's important to make sure to ask if they're able to do CBT. For families who are unfamiliar with therapy, one thing you could say is that it's like going to see a coach who's going to give you skills and tips to manage stress now and for the rest of your life.
To help you feel better, Blake, I recommend you see a psychologist for therapy. There's a specific type of therapy called cognitive behavioral therapy that works really well for adolescents with depression.
But can't I just talk to you?
That's very sweet of you, Blake, and I'll always be here for you and continue to follow you throughout this. But it is important that you see a specialist so that you can learn the skills you need to help manage stress.
So she probably would have to miss school to go to therapy.
I can't miss school. I feel like I'm already falling behind.
I understand. Most therapists can work around your school schedule so you don't have to miss that much school, which will ultimately help you do better in school. How do you feel about therapy?
I don't know.
If you think it will help, we'll give it a try.
I definitely do. So I'll have our referral coordinator send you a list of recommended therapists so that you can help make Blake her first appointment.
While you're waiting to get into therapy, there are other resources you can use, like free apps. I've listed some apps on this slide that are helpful for adolescents with depression and anxiety. Now that we've talked about psychological approaches, let's switch and talk about medication treatment for depression. So while we know therapy is the mainstay of treatment for depression, the big question is, when do you use medication? There's a large-scale, multi-site randomized controlled trial that helps to answer this question. Teens with moderate severity depression were randomized to one of 4 treatment arms: placebo, CBT, fluoxetine, or combination with CBT and fluoxetine. At 12 weeks, we saw the greatest response rate in combination therapy of SSRI plus CBT. Now, this response rate was slightly better than the response rate of fluoxetine treatment alone, and there was no significant difference between treatment with therapy and placebo in this study. Now, we know if you follow these people long-term up to a year afterwards, cognitive behavioral therapy catches up and has similar response rates to combination and to medication treatment alone. But the bottom line in what you tell families is the greatest chance to get a good response rate is with combination treatment. There are 3 things to consider when choosing medication treatment. The first is efficacy. So all of our SSRIs have excellent evidence for efficacy for treatment of adolescent depression. The second thing to consider is family history of treatment. Is there a med that mom and dad did really well on? Because if so, the teen may do really well on it as well. And then finally, the third thing to consider is the side effect profile. So which SSRI do you choose? Let's start with fluoxetine. It's very activating, so it's really good for kids who are having trouble getting off the couch. It also has a long half-life. Norfluoxetine, the active metabolite, stays in your system for about 2 weeks. So this makes it ideal for adolescents who can't remember to take their meds every single day. This one has FDA approval for the treatment of kids ages 8 and older. Sertraline, in some ways, is the opposite of fluoxetine. It tends to be more sedating, so you dose it at night. It also has excellent evidence for the treatment of anxiety. Now, the downside of both fluoxetine and sertraline is that they tend to have significant drug-drug interactions through the cytochrome P450 system. So you just have to be mindful when you're treating kids on other meds as well. And the benefit of citalopram and escitalopram is that they have few drug-drug interactions. And escitalopram has the FDA approval for the treatment of kids 12 and up. And now let me introduce my colleague, Dr. Luka Sigorovich, who's going to test your knowledge about antidepressant medication.
Please take a minute to read these questions. You may pause the video now if needed. So if your patient is having trouble falling asleep, the medication that you would choose is sertraline due to its sedating properties. If your patient is having trouble staying awake, the medication that you would choose is fluoxetine, as it tends to be more activating. If your patient is on multiple medications, choose citalopram or escitalopram, as there are fewer drug-to-drug interactions.
When starting SSRI medication, you can refer to this table, which lists dosing recommendations. In the first column, you'll see the starting dose. You'd want to keep your patient on that dose for about 4 to 6 weeks because it takes that long to see the maximum effect. Then if they're not doing well, you would increase the dose by the same increment. Dosing ranges are listed for the treatment of both depression and anxiety, and you'll notice that depression tends to respond to lower doses than does anxiety. The question often becomes, how long do you treat somebody with antidepressant medication? Well, once they've had an acute response to treatment, you keep them on maintenance for about 9 to 12 months at that dose before you make a decision about whether or not to taper off. If you do taper, you just decrease it in half every 4 weeks and evaluate them. Just like our other medications for the pediatric population, these meds are somewhat weight-based. So if you have a very large 17-year-old, you may start at a higher dose than the dose listed in the first column. And likewise, if you've got a very small 12-year-old or somebody who's younger than that, you might start at a half dose of what's listed in the first column. SSRIs tend to be really well tolerated. Some people get a little mild headache, nausea, upset stomach in the first couple days as they're adjusting to the medication, but usually that goes away. You want to worry about activation, though, which can occur in about 2% of teens and 10% of prepubertal kids on these meds. And activation looks like a diphenhydramine response. So paradoxical activation, disinhibition, and a little bit hyperactivity. If your teen becomes activated, what you would do is either decrease the dose or stop the medication. Perhaps the most controversial issue surrounding treatment with SSRIs is the black box warning that says there's an increased risk of suicidal thoughts or behavior during treatment. The take-home message is that teens are 6 times more likely to benefit from treatment with antidepressants than to experience any harm. What I like to tell patients is that there's a small percentage of the population that feels worse on these medications, but the vast majority feel better. And if you do feel worse, we just stop the medication.
In addition to therapy, I'd recommend we start a medication for Blake's depression.
I don't know how I feel about Blake taking medication. Is that something she'd have to be on the rest of her life?
No, first we'll get her feeling better. Then, after about 9 months on the medication, we would decide at that time whether it makes sense for her to taper off.
What about side effects?
So side effects are usually minimal. Like, as you start the medication in the first few days, you may feel sleepy, have trouble sleeping, or have an upset stomach, but these usually go away after the first few days. A small number of patients can feel worse or more irritable on the medication, but this is rare, and if this happened, we would definitely stop the medication. But overall, the majority of patients feel better on the medication. What are your thoughts?
I mean, we can try medication if you think it'll help. I just don't want to keep feeling this way. Do you think that I could take the medication instead of therapy?
So studies show that it's the combination of both medication and therapy that works the best for depression treatment.
So what medication are we talking about?
I'd recommend we start fluoxetine at 10 milligrams every day. You may start to see some benefit in the first week, but it usually takes 4 to 6 weeks to see maximum effect. I'd see you back in our office in about a month to check in, see how you're doing, and make sure you were able to get into therapy. What questions do you guys have?
I think you've answered all of our questions, although I'm sure we'll think of more once we leave.
Yeah, feel free when you get home if you think of anything to call our office back. I'm really glad you were able to come in today. I'm very hopeful we'll have you feeling better soon.
Me too.
Now let's apply what we've learned to a couple of clinical cases. Trey is a 17-year-old male with a 6-month history of depressive symptoms as well as some anxiety. He has trouble sleeping. Think about which medication you would choose. Because Trey's been having trouble sleeping, you're going to want to choose a sedating medication like sertraline. While the dosing guidelines say to start at 25 milligrams and keep him there for 4 weeks, since he's a larger 17-year-old, I might only keep him on there for 1 week and then get him up to 50, which might be a better starting dose for him. Then you'd keep him on there for 4 to 6 weeks, refer him for CBT, give him some apps, and then he'd follow up in clinic in 4 weeks. At Trey's follow-up visit, he tells you he's sleeping better and he's not having any side effects. His PHQ-9 score has come down to a 16, but we really want it below an 11. So I'd recommend further titration from 50 to 100 milligrams and continuing CBT. So 1 month later, Trey comes back and tells you he's feeling so much better on 100 milligrams of sertraline. No side effects, CBT's going really well. So you'd want to continue him on this medication for about 9 to 12 months before considering whether or not you would taper. If you decide to taper, you just divide the dose in half, follow him up every 4 weeks, and continue dividing the dose in half until he's off. Now let's look at another clinical case. Zoe is a 16-year-old female with a high PHQ-9 and an 8 to 9 month history of depressive symptoms with low energy. Which medication might you choose? Since Zoe has depression with low energy, you'd want to pick an activating medication. You could start fluoxetine 10 milligrams every day in the morning, refer her to CBT, and have her follow up with you in 4 to 6 weeks. At Zoe's 4-week follow-up visit, she says her energy has improved and she's starting to feel a little bit better, but her PHQ is still in the high teens. So you definitely want to increase from 10 to 20 milligrams of fluoxetine and continue CBT. At her next follow-up visit, Zoe says her mood's feeling a little bit better, but her PHQ is at 15. Now, you probably want to increase her from 20 to 30 to try to get a maximum benefit from the medication. After 2-3 weeks of starting the 30 milligrams of fluoxetine, Zoe's mom calls and says Zoe's feeling anxious and more irritated and agitated ever since the dose increase. Now, this is this classic activation response that you can often see with activating meds like fluoxetine. The treatment is to decrease the dose down and see if it goes away. If not, we may end up stopping the medication altogether. In summary, for teens with moderate severity depression, you really want to use combination treatment with SSRI medication plus cognitive behavioral therapy, and use the PHQ-9 to monitor response to treatment. We hope you enjoyed this webinar. Thank you so much for joining us.